Hello. I've made you the presenter, so you should be able to share your screen.
Excellent. Thank you.
And then just so I'm sure I'm saying it right, it's Khalid Abdel-Kader.
Yep,
Okay, awesome. Thank you.
no problem.
Peyton, can you hear me?
Yes, I can.
Okay. Yeah, I actually had to log back in because it didn't seem like you could hear me talking.
Mhm.
Is the
It must have auto muted you.
okay? Is Khaled on?
I
Yes.
am.
Oh, great! Your slides are phenomenal. My main concern is, you must talk at 500 words per minute or something.
I do talk a little fast. Why not? Thank you.
Yeah, no, I really enjoyed going through them, but I thought, whoa.
Yeah.
I take it you've probably done this before then.
So a good bit of the slides. So I went into a little more detail than I usually do about the health outcome priorities and the serious illness. So kind of dive deep into the data. But yeah, a good bit of them are stuff I like to discuss frequently at my presentations internally. So
Right. So it was fun. So last night I reread a couple of your papers, And the thing that I was impressed with is really it's only a minority of dialysis patients who want to live as long as possible, regardless of pain and suffering.
Yeah. Yeah. No, exactly. It's actually the least frequent response. So it's yeah, no, I totally
But
agree.
yet, but yet, as nephrologists, I mean, we basically assume that it's 100% of patients who want.
It's the default. That's exactly
Yeah.
right. So it's ironic that I mean I think I also have in one of the slides, which, I think as when all of us were going through, for me, going through training, spent a great deal of time being trained on renal replacement therapy planning. And then you think about it, and only 1% of all CKD patients ever reach end-stage kidney disease. And so we spend all this time training for that 1% of patients. And then what about all the other patients? Do we discuss the outcomes that they may reach in terms of disability, institutionalization, decreases in quality of life, symptoms? None of those get anywhere near the focus of that 1% that we focus on.
Right. And so that number 1%, so I knew that Ann O'Hare's study, which you quote, said that patients were 7 times, or maybe it wasn't Ann O'Hare, somebody had said patients are 7 times more likely to die while they have CKD than to progress to ESRD. Where's the 1% come from?
So if you are looking, so having said that, I am taking so when people like to, I've actually been sort of forced to use that number when I'm, that there are approximately, 20, 25 million patients with chronic kidney disease when you're using the NKF definition.
Okay.
So when you use that EGFR less than 60 or albuminuria, it ends up encompassing a huge proportion of the population. So you're saying, over 12% of the population has chronic kidney disease. And then who actually ends up out of that 12% ends up progressing to end-stage kidney disease is a tiny minority.
Sure.
Yeah, so yeah, no, I
Hi,
think
this is
there's a
Dale. Can you guys hear me now?
Yes.
Okay, hi. Hi, hello, thank you.
hi.
Hi.
Should I put my webcam on? I wasn't sure if I should have a webcam or if I should just leave the presentation on because it got confusing to me to see both. Because I could see myself, but then I wanted to actually see the presentation, obviously. So
Sure. Yeah, if it doesn't distract you, we usually have the speaker leave his or her webcam on, and Dale and I will turn ours off. So after I introduce you, I'll turn mine off.
okay.
But if it's hard, I know it can be confusing. If you want to turn it off while you're presenting, that's fine.
Yeah,
And
it's up
then
to
maybe
you.
come back. Yeah, it's up to you. Whatever makes it easier for you to present.
Okay. Well, I'll put it back on and then I don't know how to switch which one it is, but I know right now I'm sharing the presentation. So,
Yes.
okay.
And Peyton, how many people do we have registered?
We had about 40.
Great. Okay. Thank you.
And Khaled, this will go on the website and will be then available to be viewed at people's convenience. I don't know.
Sure.
I used to do lots and lots of live programs in years past, and turns out with everybody's schedule now, people just don't show up if you if you say, oh, we're going to have a workshop from noon to 3 today, and we're 10 years ago, you might have had 50 people show up. Now you might have 6. So
Yeah. We also have
nobody has.
similar
Go ahead.
issues when it comes to, I don't know if you all have had issues like that when it comes to medical student lectures. So medical student lectures have become more and more sparse every year.
Yeah, no, we exactly have that. And I've been told that out of a class of 100, as few as 6 students may show up. The average number is 15.
Yeah.
Have you had that problem too?
We have, so it makes it, I think on the positive side, it makes it so that it is a far more intimate experience than lecturing to a lecture hall. There's only a relatively small number of people you're speaking to.
Right.
You're an optimist.
Yeah, exactly.
That is a very cup half full view.
Yeah.
So one of
no,
the things are, we have Sarah Combs and, oh my goodness.
Sam Gelfand.
Thank you, Sam, have agreed to sort of co-chair for the coalition, the education pieces, and Sam is going to be trying to lead some tutorials. Have you heard that term?
I have.
Ah, okay.
I'm
So,
not on Twitter, but I actually have heard it has filtered down to me to a degree. Yeah.
yeah, so Sam's a fellow at Harvard and Palliative Care now. She finished her nephrology fellowship, and she
Fantastic.
said that's where all the nephrology fellows are getting their information is Twitter.
Oh, I've heard
So
that.
we may take, if it's okay with you, take your presentation. I mean, what, well, let me ask, what if,
Absolutely.
yeah,
Absolutely.
could we tutorial it if we
Yes,
wanted?
you can.
Okay.
You can tweet whatever you.
I'm of the generation, I cannot do it while we're listening. I'm not going to try to do it
Yeah, no, I mean,
simultaneously.
I've
but-
looked at some of because you don't actually have to be on Twitter to look at it, and I have to say I'm also of the generation where it's a little difficult for me to understand how you try and piece together these short. I'm like, I still like when I get my news, I still like to watch Frontline and long episodes and dive deep, and I'm like, wow, these are really
Yeah.
short
Yeah,
bursts.
yeah. All right, we just hit noon.
Yeah, I don't have a view that shows me people logged on. Maybe that's just your view, Peyton, that has that.
Mhm. So I'll start us off. Welcome everyone to Serious Illness Treatment Preferences of Older Adults with Advanced CKD with Khaled Abdel-Kader. I'm Peyton Smith, coordinator for the Coalition for Supportive Care of Kidney Patients. Before we begin, just a few housekeeping items. For clear reception, attendee lines have been muted. We encourage questions throughout the webinar and ask that you use the chat feature on the right side of your screen to submit questions. When submitting each question via chat, first type your comments and questions in the text box. Second, choose all participants. Third, press enter. We will attempt to answer all questions during the presentation. As we may not have time for questions at the end of today's presentation. At the end of the webinar, as you close your webinar screen, you should receive a pop-up evaluation. We greatly value your feedback. And finally, all webinars are being recorded and will be posted to the Coalition's website at kidneysupportivecare.org within a few weeks. Dr. Alvin Moss is serving as our moderator today. Dr. Moss is a professor of medicine in the sections of nephrology and palliative medicine at the West Virginia University School of Medicine. He serves as chair of the Coalition for Supportive Care of Kidney Patients. Dr. Moss is co-principal investigator on the Pathways Project, a Moore Foundation grant project to integrate supportive care into the treatment of patients with advanced chronic kidney disease and end-stage renal disease. I'm going to turn it over to Dr. Moss now.
Thank you, Peyton. It's my pleasure to introduce Dr. Khaled Abdel-Kader. He is an assistant professor of medicine in the Division of Nephrology and Hypertension at Vanderbilt University Medical Center. He completed his medical degree at Rutgers, his residency in internal medicine and chief residency at Brown University School of Medicine before specializing in nephrology at the University of Pittsburgh. In addition, he has a master's in medical education, and he's a doctoral candidate in clinical and translational science. He received federal and foundational grants to fund his research, including a K-23 Career Development Award, a Norman S. Copeland Extramural Grant, and an R01. His publications have included articles in Critical Care Medicine, the American Journal of Kidney Diseases, Clinical Journal of the American Society of Nephrology, and the Journal of Hypertension. And he's been highlighted by NPR's SHOTS health coverage. His research interests include quality of life in CKD, quality of care of non-dialysis dependent CKD patients, health information technology, risk profiling and population health management, and his future research activities, although we can tell by what he's presenting today, the future has become the present for him. He's very interested in decision-making for patients with chronic kidney disease, and he's really made some very significant contributions to our understanding of patients' preferences and priorities. And it's a delight to be able to introduce him today. I'm really looking forward to this presentation. Thank you, Dr. Abdel-Kader.
Thank you, Dr. Moss, for that wonderful introduction, and thank you for the opportunity to sort of review our work and sort of give you guys a little bit of a take on sort of my view of this area. So just to start with some objectives, so I'd like to review outcomes in advanced CKD and how they should motivate us as providers to engage in shared decision making. I think many of the individuals in the audience will probably be very familiar with this data. I'd also like us to appreciate the diversity of health outcome priorities and serious illness treatment preferences and end-of-life preferences for patients with advanced CKD, and to, in the end, briefly discuss some potential approaches to sort of efficient tools that might be able to begin conversations, initiate conversations that can lead to more advanced care planning in advanced CKD. So disclosures, I'm employed by Vanderbilt Medical Center. I've received funding from the NIDDK and Satellite Healthcare. All the views I'm going to discuss are my own. So as most of us are aware, the baby boomers are coming. So our population in both the United States as well as Europe is aging. And if you look at the number of individuals who will be Medicare eligible, and you compare sort of from the year 2000, where there were 40 million individuals, by the year 2040, 20 years from now, that number will have doubled. And that's important because when we look at the lifetime risk of advanced chronic kidney disease, so stages 4 and 5, as well as end-stage kidney disease, you look at the incidence, and if you just look at the area under the curve, you see that most of the area under these curves occur after the age of 60 and 65. You certainly see that in blacks, there is this earlier progression of chronic kidney disease, but even then, most of the area under this curve in terms of incidence of advanced CKD and end-stage kidney disease is occurring after the age of 65. And so as our population ages, we're going to see tremendous increases in the incidence, tremendous increases in the number of patients we see who have advanced chronic kidney disease. We know that advanced chronic kidney disease is a marker of poor aging. So in a landmark study from 2007 from Ann O'Hare and colleagues, when you look at the mortality rates of patients with advanced chronic kidney disease and you compare them to, and this is data I pulled from Social Security actuarial tables. So the general population, so this is not a healthy individual, this is just general population, 80-year-old, has a mortality rate of approximately 5%, so 5 deaths per 100 person years. And a patient with stage 4 chronic kidney disease has a mortality rate 3 times that. A patient with stage 5 chronic kidney disease has a mortality rate 5 times that. And that continues as you age to 90-year-olds. Again, you're seeing 2 times to 3 to 4 times the mortality rate when you have advanced chronic kidney disease. As we were discussing a little bit before the beginning of the webinar, only 1% of patients with chronic kidney disease progress to end-stage kidney disease. So if you believe in sort of the numbers that estimate the number of people in the United States who have chronic kidney disease at over 20 million using albuminuria and an eGFR less than 60 to come up with those estimates, the vast majority of those patients will die with chronic kidney disease and will not progress to end-stage kidney disease. Again, so Ann O'Hare in this publication from 2007 very nicely showed that the risk of death is greater than the risk of end-stage renal disease depending on your age and your eGFR. And so as you progress to older age groups, it requires more and more advanced disease before the risk of end-stage kidney disease is greater than the risk of death. In addition, for the patients who do progress to end-stage kidney disease, the mortality we know is quite high after initiating dialysis. And so again, if we look at the average 70-year-old who initiates dialysis, median survival is approximately 2 years. And as has been pointed out by many investigators, that survival is very much comparable to many advanced cancers. And I would like to point out that there is significant heterogeneity. So, when we're looking at, for instance, the average 80-year-old, median survival is approximately a year, perhaps a year and a half, but this varies quite a bit. And so it's useful when you're seeing patients to be able to develop clinical acumen and clinical experience that allows you to try and think to yourself, do I think this patient is closer to the 75th percentile? Do I think this is a relatively healthy patient who, for 100 patients similar to them, median survival might be expected to be 3 years, which is quite meaningful. Or is this a patient who perhaps is quite ill at the 25th percentile where median survival is as low as half a year? And I think that information is helpful when you share with patients in terms of making shared decisions and allowing them to make decisions based on their priorities. And if that data wasn't sort of pessimistic enough, the truth may actually be less rosy. So in a recent publication by Wachterman et al., so using data from the health and retirement study, they pointed out that USRDS data is based on individuals who are entered into the database. However, we know that mortality upon initiation of dialysis is highest in the first 90 days after initiation. And some of those patients will never be entered into USRDS because they die before the paperwork is processed and sent in. And so they use study from the health and retirement, they use data from the health and retirement study to look at mortality in these groups at 1 year. Older adults, so 65 to 74, 75 to 84, and greater than 85 years old. And this included everyone. And so there wasn't this selection bias of having to be entered into USRDS. And what you see is that mortality is actually higher than what I just showed you in the previous slide. Now the N is much smaller, so this is not a large national database the way USRDS is, but still relatively decent numbers. And you can see that mortality at 1 year, even in the 65 to 74 age group, is over 40%. And then when you look at by comorbidities, and frequently patients starting dialysis have many comorbidities, and you can see that mortality again at 1 year when you have 4 greater comorbidities is greater than 50%. The effect of dialysis initiation on functional status and independence is also reason to sort of give pause and to discuss with our patients what the potential outcomes are. So in this landmark study that was in the New England Journal of Medicine about a decade ago now, we have approximately 100 patients over the age of 80. And what we see is at the beginning of the study, as they initiate dialysis, the vast majority of them are alive and independent, which is this bluish color. And then over time, we see that patients progress, and a larger proportion of patients by the time we get to the end of follow-up have either died while independent or have become less independent, and so they are assisted, meaning they required a caregiver or resided in an assisted living facility, or they have actually been institutionalized and are now in a nursing home. And so it is really the minority of cases, either at 2 years or by the end of follow-up in the study, where patients were, so only about 10% of patients were alive and independent 2 years after initiating dialysis for individuals who were 80 years or older at the time of initiation. And this echoes findings that were published also in the New England Journal by Dr. Corella Tamura. Approximately 3,700 nursing home patients who initiated dialysis using the minimum data set on nursing home patients and examining ADLs, what we can see again is that from time of initiation, in terms of functional status being maintained, decreased, or death, that by 12 months, the vast majority of patients had died, and very few patients were alive with functional status being maintained. And when they looked at initiation of dialysis in terms of an independent predictor of functional status decrease, it was independently associated with a decline in functional status, taking into account baseline characteristics and sort of previous trajectory of functional status decline prior to renal replacement therapy initiation in the study. So it doesn't appear that dialysis is just a coincidence in terms of a patient who is declining and therefore requires dialysis, but dialysis may actually be an independent predictor and contributor to decreases in functional status. What is the impact of dialysis initiation on quality of life? So this again was another study by De Silva Gain and C. Jason from 2012 that looked at changes in SF-36 scores. So composite scores for mental health, composite scores for physical health. You really see no change here. And on the other hand, in this quality of life instrument, the satisfaction with life scale, you see a significant decrease following dialysis initiation. And I should give the caveat, there are other studies, longitudinal studies that have shown in younger patients and in patients who are not frail and have relatively preserved physical health, that you can see rehabilitation improvements in physical health composite scores following the initiation of dialysis. So again, there's a lot of heterogeneity in terms of you have to know your patient and understand your patient's functional status, their frailty, their comorbidities, how that is impacting them, to have a better idea of whether or not dialysis initiation is likely to lead to improvements in functional status and physical health, or whether it's unlikely to really show benefits. So based on all of the above data, the Choosing Wisely campaign, among some other organizations we're going to discuss, recommended that before the initiation of kidney replacement therapy, there should be a shared decision-making process among patients, family members, and providers, whereby patients or their proxies learn about their prognosis and the potential benefits and harms of therapy and share their values, goals, and preferences. And even more influential, so the Renal Physician Association guidelines, shared decision-making in the appropriate initiation of and withdrawal from dialysis, second edition from 2010, so recommends that we fully inform stage 4 and 5 chronic kidney disease patients about their diagnosis, prognosis, and all treatment options. We give all patients with stage 5 chronic kidney disease an estimate of prognosis specific to their overall condition, and we institute advanced care planning. And I've given sort of a brief summary that I think the audience will be quite familiar with what advanced care planning is, but for other audiences can be sort of helpful of defining exactly what we mean when we discuss advanced care planning. So how well are we doing this? And we have some data that over the past decade that has looked at this. So one is, let's look at how well patients estimate their prognosis and survival compared to nephrologists, to see whether or not we're on the same page in terms of communication between patients and providers. And for this, I'm just going to look at the 5-year data, because 1 year can sometimes be a little difficult to estimate, both for patients and providers. But I think we all are familiar with the 5-year survival data for patients who initiate dialysis. And so this was a study again by Wachterman and colleagues in JAMA Internal Medicine that asked patients about their estimated 5-year survival and asked nephrologists as well. And what we see is that the patients in general overestimated their survival. So if we just look at, for instance, the nephrologist estimated a survival of about 10 to 40% at 5 years, and we see out of 18 patients, 10 of them estimated they had greater than a 90% chance to be alive at 5 years. And then another 6 estimated either a 50 or greater % chance to be alive. So that out of 18 patients, 16 of them were biased on the optimistic side. And the same thing is true when you look at patients who the nephrologist estimated had less than a 10% chance to be alive at 5 years. What we see here is 10 out of 11 patients thought they had at least a 50% chance or better to be alive at 5 years. So it suggests we're not having these conversations. And in this study, they actually asked nephrologists whether or not they had disclosed prognosis to the patients, and the vast majority of nephrologists reported that they had not disclosed prognosis. In addition, in terms of actual survival, because we could argue, well, perhaps patients have more insight on what their survival is, and maybe nephrologists are overly pessimistic. So actual survival of this cohort was only about 55% at 2 years. So again, how well are we doing? Not particularly well. So looking at the intensity of care during the final month of life and comparing across disease states. So another organ failure, heart failure versus end-stage kidney disease, and then including cancer. And what we see is that in terms of use of intensive care unit, admissions in the final month before death, much higher in end-stage kidney disease patients. In terms of hospice use, much lower, death in hospital, much higher. And this comes from data from Dr. Wong that was in JAMA Internal Medicine. Further reinforcing this point, further data from Wachterman and colleagues, and this is looking at the bereaved family survey. And what I should sort of frame this with is that responses in the bereaved family survey, interestingly, don't show a lot of fluctuation. And so a lot of times when you see 5% change, that is actually not only is it generally significant because of the size of the sample, but it actually shows rather significant, substantial differences in care because it's very difficult to move the needle in terms of bereaved family responses. And so what we see here is when we look at the responses from patients' family members after patients with end-stage kidney disease are deceased, in terms of healthcare professionals always listen to my concerns. So 68% versus 74%. That was significantly lower. Healthcare professionals always provided medical treatment that patient and family wanted. 73% versus 79%. Again, significantly lower. Healthcare professionals always kept family informed about patient's condition and treatment. 63% versus 68%. Again, significantly lower. And when you look at died in the intensive care unit, again, significantly higher for patients with end-stage kidney disease, 32% versus 13% in patients with cancer. So this leaves, several questions that we had in terms of, are these differences that we're observing related to differences in the care delivery by providers? Are they related to differences potentially in patient priorities, or are they related to differences in causes of death and trajectories before death between end-stage kidney disease versus other organ failure, cancer, dementia, and other sort of serious illness states? And so we tried to get at this with a study using a tool that Dr. Moss is quite familiar with, the surprise question that he studied in cancer and end-stage kidney disease patients. So we looked at it in patients with advanced CKD and ensured it was valid in the CKD stage 4-5 patients. And then we used it to prospectively identify patients who were at increased risk of death, with the feeling being that instead of a retrospective look at decedents, this would be patients who providers clearly identify as being at increased risk of mortality based on their response to the surprise question, would you be surprised if this patient died in the next 12 months? And so what we see is that while in some areas we'll see there are some minor improvements, in many areas, for instance, place of death, home or hospice, minimally better among the surprise question no versus the surprise question yes patients. And in terms of death in the hospital or nursing home, very similar again. In terms of renal replacement therapy preference, most patients, again, whether they were surprise question yes or no, had made plans for initiating renal replacement therapy. We did see somewhat higher, so modestly higher plans for use of conservative management. So approximately 13% of patients with a surprise question no had plans for conservative management, whereas almost none in the surprise question yes group. But otherwise, really all of these were suboptimal. So when you look at surprise question no and use of any documentation, any advanced care planning, any advanced directive form, only about a third of patients who are surprise question no, which was modestly better than the surprise question yes. So a summary of the background material. Advanced CKD and end-stage kidney disease occur more commonly in older adults, and with an aging population, this trend will be magnified. Advanced CKD impacts survival, and the decision to initiate dialysis impacts functional status and quality of life. Knowing these things means that we should ensure that patients with advanced CKD who are making major treatment decisions engage in a shared decision-making process. And advanced care planning in older adults with advanced CKD should be standard of care. Just as a quick make sure I have everybody's attention. So unfortunately, this is not an option for most doctors. So we had a number of questions at this point. What are the health outcome priorities for patients with advanced CKD? Are some of the difference that we're seeing due to factors perhaps related to patient priorities? And another question was, are providers aware of these patients' priorities? So is part of the issue in terms of care delivery a failure on the side of providers to appreciate the priorities of patients and their caregivers? And then what are patients' serious illness treatment preferences? And so there was a little bit of data in this area and working with Mark Unruh, one of the first projects I did following renal fellowship was using the schedule for the evaluation of individual quality of life direct weighting, which is a unique quality of life tool. It asks the patient to nominate 5 domains that they find important. And then it uses a pie chart type tool to allow them to weight each of those 5 domains to determine which of those domains is most important or which part of the pie, summing to 100%, each of those domains takes. And then it asks them to rate how well they think they are performing in each of those domains. What is their experience in each of those domains, rating it on a scale of 0 to 100. And so not surprisingly, the domains that are frequently nominated are the things that most of us would probably nominate: family, health, work, financial, leisure, spiritual, interpersonal relationships. Kidney health and mobility are also important. What's interesting is that being alive, only about 8%, right up there with pets, and just a touch above sort of peace and world situation. And so there was already some, data in this area that perhaps being alive is not necessarily in and of itself the end all be all for many of our patients. So looking at this in patients with advanced CKD, so we began enrolling patients from November 2016, and for this first study through January 2018, older adults 60 years or older with non-dialysis dependent chronic kidney disease and eGFR less than 30 who were presenting for a follow-up appointment in their nephrology clinic. The patients could not be dialysis dependent. They could not have a prior kidney transplant. We excluded patients with acute kidney injury because we did not want to enrich for the sickest patients. And we also excluded patients who were presenting for an initial visit in their nephrology clinic. We wanted to make sure there had been a chance for patients and providers to communicate about their values and preferences. And so 293 patients were approached. We were quite impressed that the vast majority of patients were interested in sharing this information and enrolling in the study. So only 6% of patients declined, and another 2% found the tools, several of the tools about their preferences distressing, and that left us with 271 participants for the data we're going to discuss. And so data that we collected included the health outcome prioritization measure, which we'll discuss in the following slides, end-of-life scenarios in terms of the acceptance and whether life would be worth living from an advanced care planning workbook, came out of a VA study, serious illness treatment preferences, a question that comes out of the support study, self-rated health, ADL and IDLs, a symptom index, the palliative outcome scale, renal, free frailty, clinical frailty, and a short medical interview. We also collected from providers their assessment of patients' health outcome priorities, as well as the surprise question. The health outcome prioritization tool is basically previously validated by Dr. Freed out of Yale, and it looks at 4 health outcomes: maintaining independence, keeping you alive, reducing, eliminating pain, and reducing, eliminating other symptoms. It uses a visual analog scale, a thermometer, and asks patients to rank these 4 health outcomes, choosing sort of which health outcome is most important to them to rank the most highly, and which health outcomes are least important to them to rank lower. You cannot rank 2 priorities equally. So there is a forced choice that you have to choose which priority you think is most important. And we also collected this information from nephrology providers immediately after the office visit with their patient. So just to walk you through the script, because you can imagine this is a somewhat complicated tool. And so this is how it describes it to patients. So there are times we can't get everything we want. A trade-off is when you have to give up one thing to get another. When a doctor is trying to treat you, they usually have one of 4 goals. So keeping you alive, maintaining independence, reducing or getting rid of pain, reducing or getting rid of symptoms. I'd like you to think about the importance of each of these goals and think of a situation when your doctor can't give you all of those goals at the same time. You will have to choose the most important. And I won't read through all of this, but just to give you a flavor of the tool again, I'd like you to tell me where you would put each box on the scale of 0 to 100. The higher you put the box, the more important that goal is to you. The only rule is that you can't put 2 boxes on the same number on top of each other. For the goals of reducing or getting rid of pain and other symptoms, I want you to think about what would be most important to you if you were having pain or feeling symptoms now. By picking one of the goals as most important, it means you'd be okay giving up some of the others. For example, if you choose keeping you alive as most important, it means you can accept not being able to do some of your everyday activities by yourself or having more symptoms and pain in order to live longer. And it continues on walking through each of the different health outcome priorities and how choosing that as the most important means that there is a trade-off. And then at the end of it, they're instructed to take their time, move the boxes, and ask if they have any questions. After they're done ranking their health outcome priorities, the research assistant discusses with them in terms of what the meaning is of their ranking and ensures that that was consistent with what they intended. So characteristics of the patients who were enrolled. Average age was about 70 years with a spread of about 65 to 75. We had high educational attainment in this cohort. So nearly 2/3 of patients had some college or graduated from college. And as you would expect in an advanced CKD cohort, there was lots of diabetes, about half the patients, lots of cardiovascular disease, a good bit of heart failure, and a good bit of sort of cancer within the past 5 years. I'd also like to point out this was a very independent group of patients. So ADLs, they were fully independent, IADLs, fully independent. And in terms of symptom scores, so the POS renal score ranges up to a score of 17 items. Each is scored from 0 to 4, so a maximum score of 68. So a score of 9 shows relatively low symptom index score. So in terms of patients' health outcome priorities, on the x-axis, we have the first patient health outcome priority, And then within each bar, the second health outcome priority determines the color. And so what we see is that maintaining independence was the first health outcome priority for approximately 50% of patients. And approximately 37% of patients had a first health outcome priority of staying alive, and then much lower numbers for reducing pain or reducing other symptoms. Interestingly, among the patients who rated maintaining independence as their first health outcome priority, reducing other symptoms, reducing pain were much more frequent, or I should really say were more frequent as second health outcome priorities than staying alive. And similarly, among the relatively small number of patients who chose reducing pain or reducing other symptoms, staying alive was infrequently their second health outcome priority. So it wasn't as though most of these patients were choosing maintaining independence, reducing pain, reducing other symptoms, and then immediately after staying alive. Frequently staying alive was not one of the first two health outcome priorities, which we'll see in the following slide. And so this shows all of the data in a very granular way. And so you can see the first choice, independence, 133 out of 270 patients, so approximately half, staying alive, 96, and then much lower numbers in terms of reducing pain and reducing symptoms. And the second choice, and these are ordered based on the frequency, and you see again, reducing pain and reducing symptoms were more likely to be second choices than staying alive. Similarly, for patients who chose reducing pain or reducing symptoms, staying alive was the least frequent second choice. Now, there are a significant number of patients, so over a third, who chose staying alive as their number one priority as well. And so there's a diversity of views here, but I think it's interesting that we usually default in medicine to thinking staying alive is the number one priority and the number one goal. And that's frequently not the case. It's not even clear that it's frequently one of the top two goals that patients are considering. So we had several other questions in terms of looking at the health outcome priorities. So one was whether or not the patient's self-rated health associated with their health outcome priorities. And generally speaking, the answer was no. Now, these numbers are quite small, but if you look at the relatively small number of patients who rated their self-rated health as poor, there is a somewhat higher proportion of patients who picked staying alive as important to them. Now, this N is quite small, so 13 out of 22, so not very robust. But I do think this is an area that requires a little more research to examine whether or not these health outcome priorities are stable potentially as patients' health deteriorates, and whether it sort of differs depending on how patients sort of look at their health in comparison to other folks. So our people, now it's all of these patients, as we sort of looked at from our baseline characteristics, had relatively high frequency of comorbidities, relatively high Charlson scores. And so even these patients who are rating their health as very good and good frequently have significant comorbidity burdens, and they all have advanced CKD. And so it's really a question of sort of expectations versus observations, and whether or not people who have sort of a more pessimistic view perhaps also tells you something about their priorities. Looking at acceptability of common end-of-life scenarios, and what we've pulled out here is for various end-of-life scenarios, how many participants reported that life would not be worth living under those circumstances. And so this comes from an advanced care planning workbook, and each of these conditions is explained to the patient as being chronic and persistent. And so it would be for the remainder of their life. And so what we see is that if you can no longer think or talk clearly, 46% of participants thought that was a condition that would no longer be worth living, versus in the staying alive group, 26%. So about a 20% increase. And that number continues, that increase, as you go across from no longer can respond to commands or requests, living in a nursing home permanently, and are an emotional or financial burden to family. Now, it's interesting, some of the reviewers pointed out quite accurately that you would think for a group that has chosen sort of maintaining independence, that perhaps a larger proportion would think that living in a nursing home permanently or being an emotional or financial burden on the family would be a situation that is not worth living. I think that sort of gets to a little bit of the the discordance between when you do research on these conditions and you're sort of forced to try and create bins to understand people, and the actual sort of nuance of having conversations with individuals and figuring out what is most important to them, and what they would really like to get out of the time that they see they have remaining. And so you can imagine, for instance, a person who believes that maintaining independence is of the utmost importance to them and is their number one health outcome priority, but also would like to live long enough to perhaps see their daughter graduate from college or medical school. And so those things all get factored in together. And so it's hard sometimes to take that nuance out when you're creating these artificial bins and forcing everyone into a bin. And so it certainly gives us some insight and gives us some information about participants, but it does not replace having an in-depth, meaningful conversation and understanding your patient. So patient-provider concordance. So we found this very interesting. So the diagonal line here indicates in terms of agreement between the patient's choice of their first health outcome priority, and on the rows going across, so these are the provider's choice of first health outcome priority. And so wherever the red line is going across is where the patients and providers agreed in terms of picking the first health outcome priority of what the provider thought was the patient's first health outcome priority versus what the patient actually chose as their first health outcome priority. And what you can see is that out of 133 individuals, only 50 was their agreement. And then staying alive, out of 96 individuals, only 38 was their agreement. And as you got to reducing pain and reducing other symptoms, agreement really dropped. So 25 individuals, only 3, and out of 17, only 1. And interestingly, there were only 10 instances where the provider responded that they were unsure of what the patient's health outcome priorities were, which I think is interesting because we could imagine many circumstances where we could answer and say, well, to be honest, I'm really not sure. I haven't communicated this. I think it's sort of this narrative where we have a false sense of certainty, where we've interacted with the patient. We discuss niceties, we discuss how was Thanksgiving, Christmas, New Year's, and we have these conversations, make us feel connected to our patients. But we don't have the more in-depth, more sort of perhaps difficult, sometimes uncomfortable conversations. And so we think we know our patients, but I don't think we clearly know our patients as well as we are estimating. And so overall, when you add these up, there were about 90 cases of agreement between patients and providers out of 270, which is 1/3. Now, keep in mind, this is essentially similar to a multiple choice test with only 4 answer choices. So by chance alone, you would have expected agreement in about 25% of responses. We saw agreement in about 33% of responses. And so when we looked at this in terms of performing weighted kappas, looking absolute agreement, we saw that agreement was not much better than chance, and the kappa that corrects for chance agreement was approximately 0, indicating really no agreement. We also looked at this in terms of weighted kappa for the first health outcome priority alone, thinking perhaps providers would do better if they were just trying to figure out what was most important to patients. The kappa was only 0.1, which indicates really minimal agreement. We also looked at heterogeneity among the providers. So you might imagine, well, some providers are better than other providers. And there was one provider who had a kappa of 0.18, which is really modest agreement, and all other providers had a kappa of less than 0.1. So generally speaking, agreement between nephrologists and their patients in terms of health outcome priorities was quite low. So major findings, nearly half of a large group of older adults with advanced CKD ranked maintaining independence as their top health outcome priority, and almost as many ranked staying alive as their last or second to last priority. The first health outcome priority associated with acceptability of many common end-of-life scenarios. Nephrology providers unfortunately demonstrated limited knowledge of patients' priorities, and this really has implications in terms of how ready are we to engage in shared decision making with our patients, and are we engaging in shared decision making with our patients if we don't understand their priorities? I think this is a funny cartoon that captures some of the struggles of modern medicine. So moving on, our next question was to look at, are there instruments, are there tools that perhaps are more efficient than the health outcome priority instrument, and that still gives some useful insight and could provide an opening for providers to engage in shared decision-making conversations and advanced care planning conversations with their patients. And so again, in this case, we continued enrollment through the end of 2018. 484 participants, 484 patients approached. The majority enrolled, and we excluded patients for this was the serious illness treatment preference study. And so those who did not have a response, either because the instrument was not included during the pilot phase or because we did not record it, were excluded. And that left us with 382 participants. And so this question comes from the support study, which was published in 1995 and was a landmark study in terms of treatment for serious illness in the hospital and attempting to improve patient-provider communication and examining outcomes. And so one of the questions they used was, if you had a serious illness, what would be important to you? And we adapted it. There are versions that are strictly dichotomous, and there are versions like this that are more trichotomous. And we preferred sort of this version because we think there is, again, some nuance that is helpful for patients. And so the responses that we received, I want to try treatments for a period of time, but I would not want to suffer, was the most common. And so this is the one that's actually frequently not available if you're using the dichotomous response option. That was 35% of patients. I want to focus on my quality of life and being comfortable, even if it means having a shorter life. That was the second most frequent response, with 126 respondents, 33%. And the least frequent response was, I want treatments to try and live as long as possible. I would not want to stop treatments even if I was in pain, not feed myself. That was 20% of respondents. And then approximately just over 10% were unsure of their response. And so again, looking at baseline characteristics, we see this is, again, a cohort of older adults, so between 65 and 75 years in general, good mix of men and women. Generally a white cohort, although about 15% Black. Again, educational attainment was relatively high, so on the order of about 60%. And then when we look at comorbidities, lots of diabetes, again, lots of vascular disease, a good bit of heart failure and cancer. Charlson Comorbidity Index, so again, these are patients who have a good number of comorbidities. Their EGFR, so advanced chronic kidney disease, median EGFR is approaching 20, where we frequently have kind of in-depth conversations about renal replacement therapy options. Very independent in terms of ADLs, IADLs, and relatively low symptom index score for the POS. So they do have some symptoms, but not an overwhelming amount. So in terms of patients' responses to the serious illness treatment preference and how that correlated with their first health outcome priority, you can see that for patients who reported focus on comfort, less than 25% of them felt that staying alive was their first health outcome priority. Now, on the other hand, we moved to individuals who said live as long as possible. Approximately 60% of them reported that staying alive was their first health outcome priority. And much lower numbers reported things like maintaining independence, reducing pain, reducing symptoms. And so this does give you, so one is a metric of some validity of both instruments are concordant as you would expect. And also, I think points out that this is a much shorter instrument, much easier instrument for patients to use and can be implemented into care. And it gives you a little bit of insight into what your patients are potentially thinking. So looking at this visually, so we use this to basically look at positive and negative correlation. And so the size of the circle and the intensity of the color both indicate the degree of correlation. And so what you see is that for patients who want to focus on comfort, based on their response to the serious illness treatment preference, it was very unlikely that they felt that staying alive was their number one health outcome priority. So the circle is both large and intensely red. And then on the other side, patients who reported they wanted to live as long as possible, there's a great deal of harmony with the staying alive as your first health outcome priority. And this takes into account the sort of responses of the rest of the population. And then you can see for individuals who felt that maintaining independence was their number one health outcome priority, things like focusing on comfort, trying treatments, and not suffering were more likely to be their responses to the serious illness treatment preference. And there was more discordance of live as long as possible as a response to the serious illness treatment preference if independence was your first health outcome priority. So a question that I think comes up frequently for us as nephrologists, what about being kept alive by kidney dialysis? So could the serious illness treatment preference question be helpful in finding patients who you want to have more in-depth conversations about conservative management? And I think the short answer is yes. So when you look at patients who reported they want to live as long as possible, they were very much sort of willing to say that they are willing to do dialysis. It may be difficult but acceptable. It may be worth living but just barely, but very few of them said it was not worth living. Now, having said that, obviously all of these patients have not, so none of these patients are on dialysis, so they have not experienced the reality of dialysis. And so I think it's still useful in all patients to have, even those who are quite adamant about initiating dialysis if it becomes necessary, to have conversations after actually living with the experience of dialysis and understanding what that's like and seeing how they're doing. However, before initiating dialysis, I think the groups who report try treatments but do not suffer and focus on comfort, you can see a full 33% of these individuals thought that life would not be worth living on dialysis. And if you add in the individuals who think it's worth living but just barely, you reach a majority, and here you are just below the majority in terms of those who think that they would like to try treatments but not suffer. And I think, again, in these groups, discussing conservative management and time-limited trials, if we're looking for low-hanging fruit, especially for the private practice, very busy nephrologist who's traveling a lot, these are your low-hanging fruit. And this is sort of a simple question, and it helps you identify which patients you should be investing more time in sort of discussing what the lived experience of dialysis may be like and whether or not that's consistent with their goals. So going through the serious illness treatment preference response in common end-of-life scenarios, and what we see here is really even to a degree a larger increase in the number of participants who said that life would not be worth living than we saw with differences across health outcome priorities. And I'm not sure if some of that is due to the instrument just being easier, and so it manages to capture differences between patients, or if it's because of the somewhat different nature of the question. So one is health outcome priorities, and you can have multiple health outcome priorities. And so perhaps you have maintaining independence, and then you have staying alive as a second health outcome priority. And so when we're just looking at it as one priority and comparing, we sort of lose some of that nuance. Whereas here, it's a very simple kind of focus on comfort versus live as long as possible. What you see is that only 14% of patients thought that cannot recognize family or friends, that would be something not worth living, whereas 51% of those who want to focus on comfort. And you see again these stark differences, 10% versus can't think or talk clearly, can't respond to commands, in severe or untreatable pain, and then kept alive by dialysis, again, 33% versus 5%. And continuing on, so living in a nursing home permanently, 42% versus 15%, emotional or financial burden, 25 versus approximately 50%. Full-time care required, about 50% again versus 20, and then can't control bowel or bladders, again 17 versus 44%. I think one thing that was interesting was the kept alive by breathing machines, 27 versus 69. That's still a very stark difference. But it occurred to us that, we actually expected even a higher proportion of patients. And it sort of, again, I think underlines some of the points of any of these tools and the necessity of having conversations. It would be great to actually go back and get a better understanding of what patients thought a breathing machine was. So were they imagining this as just being hooked up to oxygen, or were they imagining this as a ventilator, and how do they imagine sort of being chronically hooked up to a ventilator and what life would look like? And part of that is, all of these instruments. So these are, by and large, patients who have not had any goals of care discussion, any advanced care planning. This is a population sort of kind of wild type. So they are in the population, they're interacting with their nephrologist as part of usual care, and we're collecting this information. You could imagine these responses, I would hope, would change as you have sort of more in-depth discussions with providers, understanding what some of these conditions are like and what they mean in terms of what your lived experience is. So patients' willingness to share their serious illness treatment preference and have it documented in the electronic record. So we were a little surprised by this. We actually thought that many patients would be worried about having something sort of simple and that they just sort of answered one day and having it recorded and feeling, well, maybe this isn't reflective of my true values, or I'd like some privacy, or I'd like to reconsider this. And what we found is overall 90% of patients were willing to have their response documented in the electronic health record and shared with all of their providers. And while there is, this was not significantly different, there is perhaps a slight trend, those who want to live as long as possible, not being quite as enthusiastic, but this was still over 85% were willing to have it documented. And so I think this again is an indicator that patients want to have these conversations with us, and they want to have their preferences and their values documented. So some take-home points. So greater than 2/3 of older adults with advanced CKD prefer treatments that do not cause suffering or focus on comfort in the setting of a serious illness. And their responses associated with acceptability of common end-of-life scenarios. About 90% of patients were agreeable to having this information shared with their providers and recorded. And some future questions we had are, can the serious illness treatment preference serve as a useful tool to assess patient readiness to engage in advanced care planning and as a point of entry for providers to initiate advanced care planning discussions in the future? So it allows you sort of a natural gate to refer to, I have this question that you answered that's recorded in the electronic record, and it says that you would prefer care that focuses on comfort. Do you feel like the care we're delivering now is consistent with that? And let's talk about, some of the things in terms of how you think you're doing right now with your chronic kidney disease and your other medical conditions. And let's talk about from there kind of what we see in the future of kind of treatment options and what you see as being consistent with perhaps what you've told us, and maybe clarifying if something has changed or what they see as as consistent with their care preferences. And so towards a more patient-centered approach. So these were just a few things, I think, in terms of I'm sort of both preaching to the choir and actually I feel like probably discussing with a group of people who know far more about advanced care planning than I do. And so there's probably a great deal that you can teach me. But these are a few publications that have sort of caught my eye. And in terms of research questions I have about advanced care planning, that I think are interesting. So one is, again, taking into account the aging population, generalist plus specialist palliative care. Nephrologists will need to be trained and must be able to do some of this advanced care planning and communication. And so we need to have these communication skills because there are going to be far too many older adults to believe that we can refer everyone to palliative care for routine advanced care planning and shared decision making. When we're trying to decide, so who are the low-hanging fruit, the Goldilocks phenomenon, I think, is a useful tool. And again, so Dr. Moss and others have done a great job of developing risk prediction models using simple tools like the surprise question to identify patients who are high risk. And then I think along those lines, this was a recent publication, and it basically used the serious illness treatment preference. So this was in JAMA Internal Medicine 2018. To prime both patients and providers. So in addition to the serious illness treatment preference, it also asked about barriers and facilitators to advanced care planning conversations of patients, and used that in order to discover sort of whether or not the patient was ready to have an advanced care planning discussion, what their priorities were, whether they thought their care was consistent with those priorities, and then going forward, sort of prime both the patient and provider for things that could be discussed to ensure that care is consistent with their goals. And it showed that in patients with stable preferences, there seemed to be an improvement of goal concordant care at 3 months after the enrollment visit. And so in conclusion, in older adults, death is a more frequent outcome than dialysis. So we really should be, for the amount of time we spend teaching about renal replacement therapy planning during nephrology training, we should be probably spending at least as much time talking about communication, goals of care discussions, because that's an outcome that we're very likely to see. And then maintaining independence is important. There's a diversity of views for serious illness, treatment preferences, and I think overall systemic changes are needed to improve care for patients with CKD. I'd like to acknowledge a large number of people who have helped me, as well as sort of funding that I've received on my projects. And if I could sort of get on my soapbox for just a minute, I'd also like to acknowledge, not many people know, but I have social anxiety, and I'd like to acknowledge individuals with mental health conditions, including those at academic medical centers, and the general biases, prejudice, and stigmatization that we regularly have to overcome. And with that, I will take any questions.
Well, that was phenomenal. Thank you, Dr. Abdel-Kader. Well, we're going to see if anybody types in a question in the chat function. So you know how nephrologists practice now. We now know what the priorities and preferences, or at least we have a really good feel from your work and your review. How would you like to see the practice? And let's talk about dialysis patients. What would you recommend as some very key changes in practice that nephrologists should implement based on an awareness of patient preferences and priorities?
Yeah, so I'd like to see, so one is, I think, just as we have these mandated, collection of quality of life instruments, I think we have enough data to say that in the majority of patients who are end-stage kidney disease, there probably needs to be sort of a mandate, whether it's through financial incentives or otherwise, for an advanced care planning discussion. So I think understanding patients' priorities, understanding their lived experience on dialysis, understanding the symptoms that they're living with, and what their quality of life is like, and then moving forward to sort of discuss kind of what is consistent with their preferences moving kind of in the future. And I think, unfortunately, the challenge is for the private practice nephrologist who's taking care of sort of the majority of the end-stage renal disease patients, time is quite limited. And so, I'm a bit of, I think, different people, and, I don't think we have enough literature in the area to sort of pinpoint. I can give you my opinion, but I can't tell you that it's an evidence-based opinion. But I think ultimately the answer is going to rest outside of the nephrologist. I do think nephrologists need to have these basic communication skills, and they need to have the ability to sort of begin these conversations and to get patients sort of thinking about it. And they also need, I think patients like to hear this information from their providers. So there's a trust factor there when you hear this from your provider who has seen you. And I think, even though we're talking about end-stage kidney disease, I also think these conversations need to begin even before dialysis, because there's even more trust, I think, before dialysis begins, and patients feel less vulnerable before dialysis begins when you're seeing them in the office in a private setting and they're not on the machine. And so I think there are a number of factors in terms of having the conversations earlier, having them in a longitudinal fashion, sort of mandating that they occur on a regular basis, and then identifying patients who might need it more frequently after major events like a hospitalization, and then potentially having someone in the dialysis, unit that is trained in these communication skills, so that they can sort of take the baton after the nephrologist has started the conversation and has sort of begun some of this difficult work, but they can take the baton and continue to move forward with it.
Wow. All right. So that's, we're talking to the ESRD network executive directors next week, and we're also talking at a CMS quality conference. So I think I will be delighted to share your recommendation with them. Unfortunately, we're at the top of the hour, but I just have to, somebody in the chat function just wrote in awesome presentation, and I think everybody who heard this would agree. So I want to thank you so much for this presentation, and we will be sure to tweet it frequently and lively, and really we'll be having newsletters to highlight future webinars. I know we have one scheduled for March, and so we're really looking forward for this to be a really good year for the Coalition for Supportive Care of Kidney Patients, and we really want to thank Dr. Abdel-Kader for getting us started off and with an excellent presentation. So thank you all very much for your time. Please be sure to complete the evaluation as you log out. Have a good day.
Thank you.
Thank you.